So I come from the small country. It's the startup nation, otherwise known as Israel. And I would like to share the thoughts about how digital health improves quality, and I hope we talk about it at the end as well. So we're looking at what's going on in Israel and other countries as far as digital health as really this hypersonic plane. And we're saying the plane left the station already. We're seeing a huge increase, as you've heard, in the number of companies that are giving us all these digital health solutions. And if we want to look at the conception of digital health, there are the few samples, but I'm going to use this framework to go over each and every one of the solutions and try to show you at the end how it does, or if it does, improve quality. So not just a buzzword, if we are able to come to our politician and key stakeholders and show them that it does improve quality, it's not just a sexy thing to do. So when we look at quality, we want to know if we have better quality, like in Israel or other countries that implemented digital health. Do we have better outcomes? Did we improve mortality? Did we improve safety? Did we reduce errors? So I'm going to look at the framework from the IOM. I'm sure some of you that are dealing with quality in healthcare know the IOM reports. And the IOM reports tells you that if you want to look at quality, you have 6 dimensions. And these are the dimensions of quality that we're going to look into them and see how each and every one of the digital health implementation did or did not affect these dimensions. And the idea is not just to do something digitally and say, okay, yay, it's digital now. We want to provide better health. So are we doing it? Okay, so that's the whole idea. And there's a vision, okay? When you look at all those articles and the companies that are speaking about digital health, they have this vision here. You can read all about it. And we are going to see if this vision actually came through. And one of the largest companies, Deloitte in Israel, talked also about this vision. And they said, yes, in a few years, this is what we're going to see. We're going to see a reduction in hospitalization. We're going to see more telemedicine. We're going to see avoiding duplications. And we're going to see a decrease in expenses. And the challenge is, of course, how we make sense of all that and how we are also bringing the innovation. And previous speakers talked about it, about the equity, about the access, and we want to see how this works for digital health. So, and of course, the pandemic, you talked about it also, that it was a big turn in the use of digital health. And maybe when we have discussions, I will tell you my experience about that. But again, we don't want to replicate what we are doing in person digitally. We want to do it in a better way. So are we doing it better? So I'm going to go over the 6 dimensions, which I showed you previously. And I'm going to highlight in dark green if the data is telling yes, significant relationship between digital health and outcome, go for it. If there are partial relationship and if there are mixed findings or no relationship. So there are, some very good articles out there, and this is a very good one that has like 54 review articles. And they looked at how did this improved care, and they highlighted a few strategies that did show how digital health improved care. And there are other 2 articles that I want to also relate to that it's a 46 meta-analysis reviews, very important. So first, let's look at the EHR, and I'm going to speak also about the decision support system, instructions, hard stops, et cetera, And you can see the highlight. What does the research tell us? So yes, the research tells us that if you implement the EHR together with decision support, like we have, if you have this diagnosis, the physician or the nurse or another clinician gets all the recommendation what they should do. So we are seeing a decrease in errors. We are seeing better outcomes. We're seeing 30% and more reduction in errors. So who's ever preventing this system should have these numbers in mind, that this is what we're preventing. So this is, of course, depends on the system that you're implementing, and not all heart stops, I mean, there are physicians here in the audience, not all heart stops are accepted by physicians. We have seen articles and studies that are showing that some of them do not get accepted, but what makes a good decision support system? If it's an automatic alert, if the physician is required to write why did not accept the recommendation, and if the recommendation is given to the physician and the patient simultaneously, and I will move on to the next thing. The next thing is the communication between providers. So we know, according to many studies that were done, communication between caregivers is considered to be the main reasons for errors. And we're looking at communication that are giving communication between patients and between the caregivers and the patients, between providers and caregiver and the patients. And we have at Maccabi, which other also very good systems in Israel, we have automatic communication with the patient in their own language, according to their age, according to their state of the disease, according to their answer, and they get a very specific targeted recommendation and a call for action. You should talk to your doctor. You should make an appointment. You should speak to the social worker. Here is how to do it, and here is how we make it. So what is the data telling us about this? So yes, we're seeing the highlight of safe. We're seeing a decrease also in errors according to that. And if you are bringing the patient into the care, then you are also improving the transfer of information between caregivers. You're reducing the time spent on documentation, but also it's a light green because there are additional research done. Here is about the patient application, the SMS, automation, remote training, etc. So all of you also familiar with safety. They said in healthcare, we said nothing about me without me. So having an access to the patient application and to the patient record is very important. We all have it in Israel. It's everything online. So I can ask for a prescription. I can talk to my physician. I can see my health record. I know if I need to take my next exam and if I need to refill my pills. Everything is online. And the patient access improves health outcomes. It's there. It's in the literature. We are seeing many, many studies that are showing it's effective. Effective meaning you're getting the right care. So what about virtual visit, remote monitoring? So here we have, you can see, yes, safe, not that strong of an evidence. Yes, effective, timely. Timely means we're getting the treatment on time. And equitable, the access. You know, Israel is a small country. We make a lot of noise, but we're a small country. And you can drive from one side to the other in 6 hours, maybe. But we do have rural areas. We do have areas that are more challenging in the sense of bringing the care. So yes, it reduces the gaps. It allows us to bring the technology there. And the remote monitoring is important and has, as we can see, improve health outcomes, shorten the waiting periods, higher accessibility, et cetera, et cetera. If we look at, I'm just going to move to the next one. If we look at the artificial intelligence, it was presented a little bit here, and the personalized medicine and predictive medicine. So I know from previous meetings that you've heard about the colonoscore, I think, at Maccabi. We have this way that if you do a simple blood test, you get the risk of getting a colorectal cancer just from a very simple blood test, and it's provided to the physician. It's on top of other tests that are being done, and it tells you if you need to have your colonoscopy done. We have the AI doc. It's in Asuta. Asuta is the hospitals within the Maccabi healthcare system. And you know the other solutions that are not Israeli specific, like for the oncology and the oncotype and for the for the antidepressants. So these are being used, and it's being used to have a better and precise care. And what we're seeing here, better outcomes using these solutions. So when we come to use the digital health, and you've seen most of the presentation has the highlights, the greens and the dark green and the light green. So you can already know where I'm going with my conclusion. But we also have to be cautious. And this is an article, and I apologize that you cannot see the bottom, but David Bates is one of the big gurus in patient safety, and he tells, do it, but move with caution. And he's talking about 4 things that we need to consider. One of them, the rapid growth sometimes lead to inaccurate solutions because not always a physician was involved, so we have to be very cautious of that. Treatment that is getting done remotely does not meet all specialties. Some specialties cannot be done remotely, and we need to be cautious about that. You cannot put your hand on the belly of your patient and sense if something's wrong. You cannot put it on the back of the neck and see if something's wrong. So we should be worried about that. We should be cautious about that. And we talked about sometimes lower documentation rate because, it's done online, electronically, remotely, and not necessarily always being documented. And the last thing is the security, the cyber attacks. I think you talked about it, Thomas. You talked about as a threat, as a cyber attacks, right? So these are 4 things that needs to be considered. But if we look at the did it come through? So overall, except for, and apologies for the economist here in the room, what the data is showing us that yes, it's safer. Many studies, more than enough to tell whoever needs to make the decision, it's safer. We see less errors, less medication errors. It's effective. Effective meaning you're giving the right medication. You're giving the right test. You're making the right choice for your patient. It's timely. It helps us to be on time. If it needs to be within a colonoscopy within 180 days, it's done within 180 days. It helps us. Equitable and patient-centeredness, it's the light green, because we're talking about access and equity. It's not just providing the digitalization. Sometimes, we have different groups, also in Israel, I'm sure in other countries, which are not ready to use the digital health, which are, this is something that's less approachable for them, and sometimes it's the age, My mother is 86, she's not going to speak to her physician online, so some of the solutions that would work for me does not work for her. So we need to think about it, okay? And lastly, I want to talk about 10 recommendations given by the WHO, and it's a document that's available online. And they say when you come to develop your digital health strategy or digital health program, these are the things you need to consider. First of all, you have to have a strategy, okay? Then you have to have a framework for monitoring and evaluating. It's not enough to have it prior to implementation. It's not enough to have a one-time thing. You need to have it ongoing, and you need to say in advance how it will be monitored, who is going to monitor it, and how is the implementation going to be measured. And you have to have procedures in place. So again, I'm going to say what's going to be done on a local level, what's done on a national level, what is the requirements from a legal point of view, risk management, quality, everything needs to be thought through. There are the measures. I come from quality. I live and breathe quality. That's my vision and mission in life. So we have to have measures in place. If I'm introducing, for example, remote monitoring of wounds that is being introduced at Maccabi, so what am I trying to improve? I have to have a measure in place, and I have to be able to look every quarter at least if I'm reaching my goal. And if I'm not reaching my goal, maybe this is not the right technology for me. Maybe I should use another one. So we have to have a measure in place. We have to have a robust evaluation methodology. We have to have the ongoing monitoring, not just the measure, because if there's some adverse events, I want to see it in time. I don't want to, that, I don't know, 3 months after implementing something, oh, by the way, you know what? Something happened to the patient. And one of the things that David Bates talks about, 2 more minutes or 1 more. One of the things that David Bates talks about is that some of the application for diabetic patients, for example, that were not vetted by physicians, actually caused patients to take the wrong dose of medication that they needed. So they found like 67 applications that were not providing the right care. So it needs to be monitored all the time. And we have to think about what again, I talked about the decentralized, what needs to be done on the local level and what needs to be done on the national level. We have to be willing to adopt, and as I said, we come from the startup nation, but we have to do it with evidence-based medicine. So not just, it's a buzzword, it's nice, I'm going to adopt it, but I have to have the evidence to adopt it. And, the WHO talks about the European repository. I think it's important to have it, I don't know, country level, on a European level, on the V4 level, whatever you decide when you put this strategy together. And the last recommendation, be progressive, but with caution, but be progressive. So just to conclude, is it better for the patients? Yes. Does it improve the quality of care? Yes. Is everything was, did we reach all our goals? Not entirely, but we have to be progressive and with caution.